Welcome to our next concept review, which is going to look at an electrolyte balance. Now, we have already talked about homeostasis as it relates to fluid balance. So now we're going to shift to taking a look at electrolyte balance and how that connects to homeostasis. And in many cases, we're going to connect this back to elements associated with fluid balance as well. As we talk about electrolytes, it's important to just take a moment and review what is an electrolyte. So electrolytes are ions that carry either a positive charge or a negative charge. The regulation of electrolytes in the body is done in order to maintain the body pH as well as homeostasis. So when we talk about electrolyte balance, what we really mean is what is the process that's going on to regulate the plasma concentration of electrolytes. So in other words, the electrolytes that are in the serum. There are several things within the body that need to happen and need to be functioning normally in order to have a good electrolyte balance. So we obviously need to start with having sufficient intake of the electrolytes. But intake really isn't enough if we can't absorb those electrolytes. So in addition to the intake, we also need to be able to absorb the electrolytes as well. So let's think about an example of this. Let's say that we're talking about the electrolyte calcium. Well, in order to be able to absorb the calcium that we take in the diet, we have to have functioning kidneys. We have to have activated vitamin D. That's important so that calcium can be absorbed from the GI tract, where it is when we take it in food, and then absorb it into the bloodstream and eventually into the tissues for use by the body. So, in addition to having appropriate intake and the ability to absorb the electrolytes, we also are going to need several key systems and organs to be functioning appropriately in the body. We need a functional renin-angiotensin-aldosterone system. We need the adrenal gland, my parathyroid glands, the pituitary glands. All of those glands have to be functioning properly. And we also need the body to be pretty efficient as well as functional in regulating the acid-base balance. Now, our focus in this concept review is just going to be looking at electrolyte functioning in general. However, it's important to remember that in order to really understand homeostasis with electrolytes, we have to be aware that there are a whole host of other things in the body that have to be working correctly. As we progress throughout this course, we're going to be talking about different disease processes that are going to alter electrolyte balance. So you will find yourself referring back to the notes that you take on the concept of electrolyte balance quite a bit this semester. Now, obviously, when we're talking about electrolytes, we're going to talk about some labs that we need to look at, specifically my electrolyte panel. However, there is more to electrolyte balance than just the electrolyte level themselves. We need to make sure that we're considering osmolality, both serum osmolality as well as urine osmolality. We need to take a look at the BUN and creatinine level. That's going to give me some information about my patient's kidney function status. And we also need to take a look at the BNP level. That's going to give me information about the fluid load that is on the heart. Fluid connects to electrolytes in many different ways. Remember, when we're measuring electrolytes, we're measuring concentrations per volume of fluid. So we're going to be looking at per liter or per deciliter of fluid. So if our fluid level changes in the body, this is going to have an impact on that numeric lab value that we get with our electrolyte labs. These electrically charged ions are going to move fluid within the body. They're going to be involved in the production of energy. They're going to help out with muscle contractions. They have a whole host of functions within the body. So it's going to be important that you think about electrolytes in combination with fluid, as well as with the role that these electrolytes have in bodily functions. In the fluid section, so the video on fluids, we talked about osmotic potential. And we mentioned that sodium, which is an electrolyte, has a high osmotic potential. So in other words, water or fluid is going to move to where sodium is at. So if I change the sodium level and I'm seeing that my patient's sodium level is changing, that is actually going to change the movement of fluid. You are at a much higher level in the nursing program now, so you should be thinking about electrolytes from a conceptual basis and pulling in understanding of different disease processes, understanding of fluid elements, and then looking at electrolytes in isolation as well as conceptually. You started out in the beginning of the nursing program looking at electrolytes in isolation. You were trying to get an understanding of what each electrolyte means and how it works in the body. Now we're going to advance this, and I want you to start thinking about the electrolytes as they work together with each other, how they work with fluid regulation, as well as how they work with acid-base balance. Now, there are a variety of body systems that are going to be involved when it comes to the regulation of electrolytes. The endocrine system, your renal system, cardiovascular, gastrointestinal, all of those systems are going to play a really key role in the regulation of electrolytes. Now, as we progress throughout this course, we're going to focus in on several different conditions that are going to impact a lot of those body systems. So you're going to see that we revisit this discussion on electrolyte imbalances throughout the entire time you're here this semester. Let's talk a little bit about some of the major electrolytes. So we have them organized here on this slide based on cations and anions. So a cation is going to be a positively charged ion, and your anions are going to be negatively charged ions. The major intracellular electrolytes, so the electrolytes that are more predominant inside the cell, are potassium and magnesium. The major extracellular electrolytes, so the electrolytes that are more prominent outside the cell, are sodium and chloride. Most of the electrolytes that we're going to talk about in this section come from food intake and fluid intake. However, our patient's status in terms of their health and what other disease processes they may have can impact electrolyte levels as well. It is important to keep in mind that your actions as a nurse can also alter your client's electrolyte levels. So think about all of the medications you've already discussed in nursing school, and you've learned how those can impact electrolyte levels. IV fluids can impact electrolyte levels as well. This semester, we're going to be exploring the administration of blood products that can really alter your patient's electrolytes as well. I provided the normal values for each of these electrolytes that I would like you to commit to memory for this semester. These are the most common ranges. However, you'll notice that each lab facility and even each of your different textbooks have a slightly different value for what they consider norm. And that's really just based on when we're in the lab, what equipment that they're using, what type of testing is done. But this gives you a nice general range or a general reference point that you can use to help you understand what is a normal value so that we understand what might be going on when these values fall outside the normal ranges. One point that is really critical for you to remember is that when we are measuring these lab values, we are measuring the concentration of electrolytes in the serum. The serum is the extracellular fluid, so it's my vascular fluid. We are not measuring the total body concentration of these electrolytes. It's just what we measure when we do a blood draw, so what's in the serum. So this is going to be important to understand as we start to connect the concept of fluid balance, electrolyte balance, as well as acid-base balance. Let's start off our discussion with some sodium imbalances. Sodium is a great place to start because it's the major extracellular cation. So in other words, it's one of the major positively charged electrolytes that's located outside the cell. It's important to just get a general understanding of what sodium does in the body first so that you can understand what happens when there is an imbalance in sodium. Sodium plays a really big role in the nervous system, particularly in relation to the excitation that occurs outside of the cell. Also, as we've already discussed, it has a really high osmotic potential. So we know that it's going to have a significant impact on fluid balance in the body as well. The majority of sodium is found in the blood plasma. Remember, your blood plasma is part of your extracellular fluid. And we have osmotic potential with sodium, which means that sodium is going to draw water to it wherever the sodium goes. If we have a patient whose serum sodium level goes up in the body's going to try and compensate for this high osmolality by pulling fluid. And it's going to pull that fluid from the interstitial spaces and even from the intracellular spaces to try and move that fluid into the vasculature where we have lots of sodium and try and dilute down that sodium. So when we talk about hypernatremia, this means that we have too much sodium in comparison to the amount of fluids in the plasma. So in other words, the patient has a high serum osmolality. A lot of different things can cause hypernatremia. Your patient could be very dehydrated. Maybe they've had a fever for a long time. We're actually going to be exploring some endocrine conditions this semester, such as diabetes insipidus and Cushing syndrome, which can also trigger hypernatremia. Now, many of your patients that have hypernatremia will be really thirsty, but this will only occur if they have an intact thirst mechanism. Remember, your older adult population does not have the same efficiency in their thirst mechanism, so you may not get this thirst sensation as an early sign in these patients. Your patients will typically have dry skin and dry mucous membranes, but they could also have edema. Now, because of the role that sodium plays in the neurological system, you will see that your patient often has some neurologic symptoms as well, such as restlessness as well as confusion. The treatment associated with hypernatremia is going to be dependent upon the cause, and you will hear me say that as we talk about each of these electrolytes. We have to figure out what's causing the problem before we can try and just treat the symptom or the sign. Typically, they will have the patient increase fluid intake if they can tolerate it. They may also use some diuretics to help pull off the sodium as well. If the hypernatremia is associated with a chronic condition, they will also restrict sodium intake in the patient's diet. Now let's take a look at hyponatremia, so a low sodium level. And essentially when we talk about hyponatremia, typically we're going to say that your patient has a hypotonic fluid imbalance. And that's because they have decreased solute, which what we're talking about here is sodium, and increased fluid or water in the bloodstream. Oftentimes, we see this condition when patients have a comorbidity that causes volume overload, such as your patients that have heart failure, renal failure, or liver failure. A really big concern with hyponatremia is cerebral edema. As we already mentioned, sodium plays a big role in the central nervous system and how that functions. So when we have a low sodium level, this is going to cause a shift in our fluid. So water is going to move into the cells. And the problem is that when we're in the brain, if we have too much water there, there's really not much room for that. So we start to see that the cells swell up, and eventually we're going to develop cerebral edema. Typically, your patient will start out with complaining of a headache, and they may appear confused. If it's not addressed, your patient can have a seizure as well as go into a coma. This is another situation where before they can engage in appropriate treatment, they have to know what's causing the hyponatremia. Now, in general, they will restrict fluids to try and correct the osmolality, but sometimes we'll see that they give diuretics. Sometimes they'll even use a hypertonic fluid. Just depends on what the cause of the hyponatremia is at that time. Let's take a look at potassium next. Potassium is the major intracellular electrolyte, so it's the major electrolyte that we see inside the cell. Because the majority of our potassium is inside our cells, this means that we only have a small amount in the extracellular fluid. This also means that if the patient's potassium level changes even just a little bit, we're going to see some significant complications that start to occur. It is really important for you to watch your patient very closely when they're suspected or at risk of having a potassium imbalance. There are a lot of different conditions. There are medications as well that can predispose patients to potassium imbalances. So it's very important that you're monitoring these patients because a shift in the potassium, whether it's going up or down, can be deadly. When you think about potassium, just in general, the overall function of potassium is to allow for excitation to occur inside of cells. So when you think of potassium, I want you to think about the cardiac system. And anytime we change a potassium level, it puts your patient at risk for developing arrhythmias because we're altering the excitation that can occur. Now, potassium is also responsible for the conduction of nerve impulses as well as skeletal muscle activity. So knowing those major functions really helps illustrate what some assessment findings might be if your patient's potassium level goes up or goes down. Let's start with talking about what happens when a patient's potassium level goes up and they have hyperkalemia. So if we have too much potassium, that's going to cause overexcitation, particularly of the cardiac cells. And that gives that really classic tracing on an EKG where we have these tall, or what we refer to as peaked T waves, as you can see in this section of a tracing here. The arrhythmias that occur from this can be fatal, so it's very, very important you pay close attention to your patients. Now, initially, when your patient initially develops hyperkalemia, usually they're going to have a lot of cramping. We're going to see overexcitation of the muscles. Sometimes they even have twitching that's present. But over time, we're going to notice that their leg muscles are going to get pretty weak. And your patient may even lose the ability to move some of these larger muscle groups. They can go into paralysis. The most common cause of hyperkalemia is actually kidney disease, and we are going to explore kidney disease a little bit more when we get into the renal section. But if you remember, the kidneys are responsible for excreting potassium. And if the kidneys aren't working, they aren't functioning appropriately, they're not going to be able to excrete the potassium. So that's going to cause the potassium level in the serum to go up. We also can see hyperkalemia from crush injuries. So let's say your patient's been in an auto accident, they come into the ED. We're breaking open a lot of the cells because of that crush injury, and the potassium is going to leave those damaged cells. So their potassium level in the blood will then go up. I'm sure you're already familiar with a lot of medications that can change your potassium level as well. So things such as ACE inhibitors, particularly in our patients that have diabetes, that will increase their potassium level. Potassium sparing diuretics, those will cause a rise in potassium as well. When we think about the collaborative care, again, we have to see what is the underlying cause. What is causing the hyperkalemia? If it's caused by a potassium sparing diuretic, the healthcare provider may need to change the diuretic. However, you may see that the patient is required to limit potassium in the diet. We try and start with the least invasive approaches before we move to the more invasive approaches. But let's think about our renal patients, right? My patients that have renal disease, particularly if it's a chronic renal disease state and that potassium level is going way up, they're going to have a more invasive treatment approach, such as dialysis, to be able to bring down that potassium level. Now, if our potassium level gets too low, such as the case with hypokalemia, we're going to have some problems as well. Now, most patients are going to develop hypokalemia because they're using potassium wasting medications, such as laxatives or your loop diuretics. However, some patients that have excessive vomiting, a lot of diarrhea, or even excessive sweating, diaphoresis, they can also develop hypokalemia. So remember, potassium plays a key role in the repolarization processes. So if we don't have enough potassium, the neuromuscular cells and the cardiac cells cannot repolarize. This means that they're not going to be able to fire action impulses in the same rapid, organized way that we are used to having. So the result is going to be muscle weakness. The patients will also report cramping, particularly in their lower extremities and their legs. Some patients will even report numbness and tingling sensation. Also, because my cardiac cells, they rely on having normal potassium levels. They need good homeostatic balance of potassium. So if there's not enough of potassium available for repolarization, you're going to see that your patient actually develops bradycardia in most cases. Usually, as we look at the EKG tracing, we'll see a real flat T wave, as you can see shown here. It's really flattened T wave. And sometimes your patients will even have a U wave. You'll see a really prominent U wave present. It's important when we look at a patient's potassium level that we work together with the healthcare team to try and figure out what's the underlying cause. Why did that potassium level drop? Because what we may need to see is that there needs to be a change in their medication regimen. Maybe your patient just needs to have some potassium added to the bag of IV fluid that you have hanging. Now with potassium, it's critical that it's diluted, and you always have to put it on a pump. That's really, really important because you can kill your patient if potassium is given inappropriately. Sometimes they may just encourage the patient to take in more potassium in their diet, or they may just add on some potassium supplements to their medication regimen. Let's take a look at calcium next. Calcium is found mostly in the bones and the teeth. The vast majority of your calcium is going to be located in the bones and the teeth, and just a really, really small percentage is going to be dissolved within the blood. At this level in nursing school, we're going to be looking at total calcium levels. But it is important to remember that about half of the calcium that's in the blood is actually bound to plasma protein. Specifically, it's bound to albumin mostly. And then the rest of it, the other half that's in the plasma, is just kind of free floating through the plasma. So when we have patients and we're looking at are they symptomatic or not with their calcium imbalance, we really are going to see symptoms in patients who have changes in their free-floating calcium levels, and not as much as when they have a change to the calcium bound to albumin. So again, before we look at specific imbalances, let's review what the primary role of calcium is in the body. The primary role of calcium is to contribute to neuronal excitability. So in other words, what we're looking at is excitation of the motor neurons. So how are we sending a signal, let's say, to the muscles, telling those muscles to contract? Remember that when we're talking about calcium, it's the presence of calcium inside the cell that causes the contraction. But what we're measuring when we draw our serum lab values is the calcium that is outside of the cell, that's in the blood. An easy way to kind of help you understand calcium's role is to think about calcium kind of as being a stabilizing force at the membrane. So what's happening at that membrane when calcium is present? So a patient who has high calcium levels in the blood, meaning that there's more calcium outside the cell, it's not going to be able to contribute to the contraction process. So we're going to see that the patient has decreased muscle contraction. Whereas a patient who has low calcium outside the cell, that means there's more calcium on the inside of the cell. So it's going to be involved in overexcitation of that cell because there's not enough calcium in the bloodstream to stabilize those membrane channels. So that patient is actually going to have more muscle contractions, even spasms. Let's look at each of these imbalances individually so we can get a better understanding of what this means to me as a nurse. What are the assessment findings I'm going to see? What might I need to do as part of my collaborative care? So we are going to start out with hypercalcemia. Hypercalcemia means that we have a lot of calcium in the blood. So all of the excess calcium is working to stabilize the membrane channels. So there's not going to be as much of an ability for the muscles to contract. So what we'll see is your patient's deep-tended reflexes are going to be quite decreased. Now this change in contractility and this change in excitability is also going to impact your GI tract. So we're going to see that motility is going to slow down because we don't have those contractions present. Many times your patients will tell you that they're experiencing deep bone pain as well. Now some of your patients are also going to display some cardiac arrhythmias because if I have decreased excitation at those membrane channels when we're looking at the heart muscle, that can actually lead to cardiac arrest. So let's talk about collaborative care. What do you think we might need to do? Well, obviously we have to figure out why is this occurring. Typically what we'll see is your patient will need to have an increase in their fluid intake, because what we want to try and do is dilute down all that excess calcium. Because your patient can develop fatal heart rhythms, usually you'll see that they are placed on some type of continuous cardiac monitoring. Sometimes they'll even give the patient furosemide, because furosemide is going to help to dump that excess calcium. But you've got to be really careful, because we need to monitor our patient's fluid balance really, really closely if they have hypercalcemia and they're using furosemide. So again, think about your patient who has hypercalcemia. There's more calcium outside the cell. There's a lot of calcium in the serum, so that calcium isn't getting into the cell, so it's not able to contribute to the contraction process. So overall, I'm going to see decreased excitation and decreased contraction. Some people think of calcium by saying the phrase calcium calms, but that's only true when we're talking about the calcium in the serum, because calcium itself, when it gets in the cell, actually contributes to contraction. So let's talk about what's going on with hypocalcemia. What happens when that calcium level in the blood is really low? Well, that means we've got a lot of calcium on the inside of the cell. So what we're going to see is overexcitation. We don't have enough calcium in the bloodstream to really stabilize those membrane channels, so everything is going to start contraction. You're going to see spasms occurring. You're going to see tetany. Tetany is an involuntary contraction that occurs in our muscles, and the most common ones that we see with hypocalcemia include Trousseau's sign and Chvostek's sign. Trousseau's sign is elicited when we put on a blood pressure cuff. We'll pump it up above your patient's systolic blood pressure, leave it on for a few minutes, and we look to see if there's a carpal spasm. If a carpal spasm is present, that is associated with hypocalcemia. Chvostek's sign is when we tap their cheek right along where the facial nerve runs through, and we see if there is a spasm or tetany on that side. If the hypocalcemia is quite severe, you could even see seizures, and you can also see heart dysrhythmias as well. Most of the time, because of that low calcium level being present, we're going to start to see that the muscles in the GI tract are going to contract continually. And if I have continually contracting GI tract muscles, I'm going to start to see that my patient experiences vomiting as well as diarrhea. Now we have to pay close attention when we're talking about the collaborative care of a patient with hypocalcemia. Obviously, we do need to figure out what is the underlying cause and correct that. But we also need to replace the calcium. The challenge is that we can give a lot of calcium to the patient, but if we're not giving vitamin D with it, it will never be absorbed into the bloodstream. So yes, we have to replace the calcium, but we also have to replace vitamin D. So you often see that they will have the patient add on some calcium and vitamin D supplements to their medication regimen, or add those into their diet. Remember, our bodies cannot effectively absorb calcium without activated vitamin D. So we need to see that they're increased together. Oftentimes, they will order continuous cardiac monitoring as well, particularly if they're going to use calcium gluconate, which is an IV product that could be administered. Let's move on to magnesium. Magnesium is a major intracellular cation, which means that we have more of it inside the cell than outside the cell. This is why you're going to see that a normal serum magnesium value seems kind of low, because what we're measuring is that extracellular fluid outside of the cell. What is the concentration of magnesium that's located there? Let's go back to anatomy and physiology for a moment and think about the basic function of magnesium in the body. Overall, the primary role of magnesium is to control the relaxation of muscles. If we have too much magnesium in the blood, in essence, we are over-relaxing my muscles. So my muscles are going to be really relaxed, they're going to be really weak, I'm not going to be able to get good deep tendon reflexes. Now remember, we have muscles located throughout our entire body, and these muscles have a variety of different roles, and there are a variety of different types of muscles. But each of them are going to require a balance of magnesium. And the challenge is that when we have hypermagnesemia, what we're going to see is the muscles are really too relaxed all throughout the body. So when we talk about the muscles in the blood vessel, when those muscles relax, those smooth muscles relax, the result is going to be vasodilation. When I dilate the blood vessel, my patient's blood pressure is going to go down. If I relax the muscles in the heart and the muscles in the lungs too much, they're not going to be able to do their job as well. So you'll see that your patient can go into a cardiopulmonary arrest state. Now, when my patient's magnesium level gets too low, we see the opposite effect occurring. So if I don't have enough magnesium, that means the muscles can't relax at all. They're just too excited. And when they get overexcited, that's when we start to see tremors occur. You're going to see very hyperactive deep tendon reflexes, and you may even see clonus present. Now, my nervous system is going to become overactive as well, and we're going to start to see seizure activity. Your patients can become very confused when we see that magnesium level is going down. Now, again, because my heart is a muscle, we're going to see an increase in the patient's heart rate because we're having overexcitation of the cardiac muscle. You will explore magnesium imbalances a bit more when you get in the OB arena. So clinically, you may find yourself administering magnesium when you work in the OB environment. And one of the reasons that they do that is to try and relax the uterus from contracting too much, particularly my patients with preterm labor. We also see it used sometimes in a state known as preeclampsia. That's kind of an older term for the state, but it's a state of preeclampsia. So when we give the magnesium is going to cause vasodilation because we're causing that relaxation by giving magnesium. And with vasodilation, I'm going to see a drop in blood pressure. So again, in the OB section of this semester, you're going to explore magnesium in more detail. However, conceptually, what I want you to get here in this Med-Surg course related to magnesium is an understanding of how this electrolyte works really impacts the assessments that I'm going to do with my patient. So for example, if my patient has a magnesium imbalance that I see on a lab report, I need to know how is my patient tolerating this imbalance? Are they symptomatic? So in order to understand that, I'm going to have to assess deep tendon reflexes. If my patient is getting too much magnesium, this is going to be a cue that really helps me recognize early on is I'm going to see a diminution in their reflexes. So I see that diminishing of their reflexes. That's a really key cue for me as a nurse because I'm going to say, hey, I've recognized early my patient's magnesium level has gone up and they're really symptomatic because everything is too relaxed. And that's important to be alert to because if I don't catch that, the next change I'm going to see is I'm doing CPR on my patient because they've gone into cardiopulmonary arrest. So we want to try and prevent moving into respiratory and cardiac arrest. And the best way to do that is early assessments. It's you as the nurse at the bedside that recognizes these deep tendon reflexes are really relaxed. They're really diminished. I need to know what my patient's magnesium level is because I don't want them to go into cardiopulmonary arrest. So your assessment at the bedside is really your most critical role as a nurse because you are the one that is going to identify this change. All right, let's shift gears and talk about phosphorus a little bit. Phosphorus is the primary anion that's located inside the cells. And phosphorus really plays a key role inside the tissues of our body. It also is involved in helping us form ATP, so our primary energy source. It helps support a good acid-base balance. It helps support the neurological system. We use phosphorus as we metabolize carbohydrates, proteins, and fat. You'll notice that phosphorus plays a role in bone health as well as our dentition. We're going to talk about phosphorus quite a bit in the sections on endocrine conditions as well as on renal conditions, but we're going to get kind of a basic overview of phosphorus here. When we talk about phosphorus, it's important to remember that phosphorus and calcium are going to have an inverse relationship, particularly when it comes to the renal system. So the renal tubular reabsorption process of phosphate is actually going to be inversely regulated by our serum calcium level. So let's break that down just a little bit more. Since I have this inverse relationship, what I'm going to see is that if a patient has an increase in the phosphorus level, there's going to be a decrease in the calcium. If they have a decrease in the phosphorus level, there's going to be an increase in calcium. So what we're going to do right now is just explore phosphorus imbalances in general. Just get the concept in mind so that you can then apply this concept into other conditions that we're going to talk about throughout this course. Let's look at the hyper state first. So hyperphosphatemia. So this is when we have an excess of phosphorus in the serum. And usually this is going to be caused by kidney disease, either acute or chronic kidney disease. Now we can also see it with hypoparathyroidism, and usually we're going to see respiratory or metabolic acidosis accompanying it as well. And we're talking about this a lot more when we get into the acid-base section. But the most common reason we see hyperphosphatemia is with an initial kidney injury. Most of the time when we talk about an elevated phosphorus level, what we're going to see is that the patient is usually going to show signs and symptoms that we associate with a decreased calcium level, and that's because of the inverse relationship. So you actually already know the assessment findings that you're going to see in a patient with hyperphosphatemia if you understand the assessment findings I would see in a patient with hypocalcemia. The most common sign that's going to be present is tetany. And the tetany is occurring because of the drop in the calcium related to or in response to an elevated phosphorus. When we think about the nursing care for patients that have an elevated phosphorus level, we want to try and find ways to reduce phosphorus. So we can start out by reducing it in the diet, as well as in any medications they may be taking. There are several medications that are quite high in phosphate, so we want to reduce those as well. But the only way that I'm really going to be able to see how well things are working within this patient is to check their urine output. If I don't have sufficient urine output, that means my kidneys are not going to be able to excrete the phosphate. So reducing in the diet might be helpful, but we need to start looking more at what is the actual cause and addressing the underlying cause. Now, for now, I just want you to review the concept of phosphorus imbalances. We're going to spend quite a bit of time talking about the relationship between kidney disease, phosphorus, and calcium, and how all of those imbalances change up as we progress with kidney disease. When we get to the renal section of this course, it's a really complex relationship. It goes well beyond the extent of what we're trying to do in this concept review, but don't worry, we are going to come back to it when we get to the renal section. For now, I want you just to focus on general findings as well as general nursing care. So let's explore what happens when the phosphate level or phosphorus level is lower in the serum. We often see this in patients who have diabetic ketoacidosis. We can see it in patients that have hyperparathyroidism, and we can also see it in respiratory or metabolic alkalosis as those states kind of accompany it. Sometimes we'll see it with burn injuries too. A burn injury can lead to quite a bit of loss of phosphate. In one of the med-surg labs that we do this course, we're going to talk about TPN, we're going to talk about parenteral nutrition. When we talk about parenteral nutrition, we always have to think about phosphate. So a big challenge with parenteral feeding or parenteral nutrition is that it can actually drop our patient's phosphate levels. So we start out, let's say you have an older adult patient, maybe you have a patient that's had eating disorders such as anorexia nervosa. Regardless of what the underlying cause is initially, if we have a patient that hasn't been eating well, they haven't been taking in food, they're not getting in their nutrition, and we decide, or we work with a healthcare provider and team to decide that parenteral nutrition is needed. Well, they develop something known as refeeding syndrome. And what happens is that we start to give them a ton of calories. and we give them nutrients. And what happens is the body says, oh, there's lots available to me. I'm just going to pull all of that stuff inside my cell. We see this particularly when we're talking with the body with glucose, right? We're giving a lot of glucose through this parenteral feeding, so the body dumps tons of insulin. Well, the insulin is going to pull the glucose into the cell, but it's also going to pull into the cell the phosphorus. And so that's where we start to see a decrease in their phosphorus levels in the serum. So before we dig into looking at some of the assessment findings we might see in these patients, let's do just a quick review of phosphorus itself. Remember that phosphorus is going to be responsible for ATP production in my energy stores in the body. So we need phosphorus to form ATP. We also need phosphorus to help us form a substance known as diphosphoglycerate. This diphosphoglycerate is what allows hemoglobin to release oxygen when it gets to the tissues. So now let's think I have a patient whose serum phosphorus level is low. Well, the majority of signs and symptoms this patient is going to display are going to be associated with a change in our body's ability to store energy, as well as our body's ability to release oxygen at the tissues. So in essence, we're impairing that oxygen delivery really to the tissues. And this ends up causing a whole host of neurological complications. And then when we think about the hypoxic state, hypoxia is going to trigger the body to say, hey, I'm not getting the oxygen I need at the tissues, so I'm going to increase my respiratory rate, because the body thinks that, well, we're not bringing enough oxygen in. In reality, you're getting enough oxygen in, it's bound to that hemoglobin, but we just can't release it. Well, when we increase our respiratory rate, we start blowing off a lot more CO2, which puts your patient in a state of respiratory alkalosis. Well, unfortunately, when we're in respiratory alkalosis, your body starts to pull even more phosphorus inside the cell. And now I'm making that low phosphate level, the hypophosphatemia, even worse. We also don't have sufficient energy stores, so muscle damage is going to occur because the muscles aren't getting enough energy, they're not getting enough ATP. Your patient's going to feel very weak. When we talk about weakening of the respiratory muscles, eventually we're going to see that there's going to be cardiopulmonary problems that occur. Your patient can develop hyperglycemia due to the insulin resistance. So as a nurse, when we think about this, we really need to prevent this from ever happening. This means I have to be really, really careful when we're giving parenteral nutrition, pay really close attention to what the components are, the amount of calories that are being given, because we don't want this really odd or rapid shift between the intracellular fluid and the extracellular fluid electrolytes. If your patient tolerates oral intake, they may just increase phosphorus in the diet. So give me fish or milk, even whole grains has some phosphorus in it. And they could add phosphate supplements as well. Again, it just depends on what the underlying cause is. Let's finish up our look at individual electrolytes with talking about chloride. Chloride is the major anion of the extracellular fluid. However, it's important to remember that with chloride, we really find more chloride in the interstitial fluid. So that's that fluid that is in between all of your cells. And then we find a lot of chloride in the lymph fluid. There really isn't a lot of chloride in the blood. We also have a lot of chloride in my gastric and my pancreatic juices. And this occurs because when we think about chloride, where is chloride formed? Well, chloride is going to be formed in the stomach, right? It combines with hydrogen so that we can make hydrochloric acid, which we'll talk about a little bit more when we talk about some GI conditions. So as long as my chloride levels stay in balance, I'm okay. And usually just by eating sufficient amounts of chloride, usually through salt that we're taking in our diet, as well as having functioning kidneys that are able to excrete it, as well as to, a much smaller extent, we can excrete some chloride in our feces. Usually we do okay with chloride. So we tend not to see this value as much of a focus as the other labs on electrolytes that we've talked about. But we are going to look just briefly at what can happen with a chloride imbalance. Now, we already talked about serum osmolality and its relationship to sodium, but serum osmolality actually relates to chloride as well. So essentially, when you're thinking about sodium and chloride, these are really the most prominent electrolytes that we see in the extracellular fluid that are going to work together to determine osmotic pressures. And again, we tend to focus more on sodium, but chloride does play a role. We're going to talk about bicarbonate a little bit more when we get into the acid-base balance concept review, but bicarbonate has an inverse relationship with chloride. So when my chloride levels start to shift from the plasma and they move inside the cell, so we have this chloride shift that's occurring, and again, when they're in the plasma and they move inside the cells they're moving into are the red blood cells. Well, what that does is it triggers bicarbonate to move back into the plasma. So chloride is moving into the blood cell, so chloride levels are going down, and then your bicarbonate is going to move out and back into the plasma, so your bicarbonate levels are going to go up. When we think about the bigger picture as we talk about electrolytes, usually when we're thinking about imbalance in sodium or an imbalance in chloride or an imbalance in bicarbonate, when any one of those levels changes, the other two are going to be impacted as well. So you want to look at it really holistically, and then because we're talking about bicarb, it's important that we consider acid-base balance on top of that. So let's look at hyperchloremia first, so an elevated chloride level. Oftentimes, we're going to see an increased chloride level accompanied by an increase in sodium. So your patient may also have hypernatremia. And usually because of the exchange of the chloride and bicarb, or that changing out of the chloride and bicarb going in opposite directions, you'll see that your patient has decreased bicarbonate. Now, bicarbonate is a buffer, so you can think about it as a base. If I'm losing base, that means my pH in my blood is going to become more acidic. If my patient really has a problem with the elevated chloride levels, it's usually because we caused it. Unfortunately, if your patient is getting an IV fluid that has a lot of chloride in it, that can really trigger the hyperchloremia to occur. It's rare that it just occurs independently on its own without some intervention triggering it. Although it is possible if somebody has excessive sweating, let's say they're losing a lot of water, they're losing a lot of sodium, but we didn't see as much chloride loss, well, because we've lost all that excess fluid, it's going to appear as if their chloride level is a little bit higher. When you think about a patient who has an elevated chloride level and you're wondering, what's that patient going to look like? What are the clinical manifestations or the assessment findings that I'm going to see? I want you to imagine the assessment findings that you would see with a patient who has metabolic acidosis, because those are the similar assessment findings that will be present. So your patient might have increased respiratory rate, they could be weak, we could see alterations in their respiratory status, they might be confused, they might have more trouble with making kind of calculations. As we go through and do a mini mental status exam, they would struggle with a lot of the retention and calculation elements of it. And oftentimes we'll see that hypertension is going to occur, so an increase in blood pressure because of the connection between chloride, sodium, and fluid. In terms of the collaborative care, we really need to monitor cardiac status. Usually they'll have an EKG going. Oftentimes the focus is what is causing this. If we're the one causing it, we need to change up the IV fluid that's being used. Sometimes they'll switch to a hypotonic IV solution, but we have to make sure we know what the chloride volume is within that solution before we just switch that out. But whatever underlying fluid and electrolyte imbalances they have, that's really what we want to look at treating first. And then usually the chloride will correct itself with treatment of those underlying causes and imbalances. Now, when your patient has a chloride deficit, that's usually to something that's gone on in the GI tract. So it could be that your patient has gastric surgery and we've altered the cells that produce chloride, or it could be because we're suctioning too much out. So they may have an NG suction in place and we're just constantly pulling out the chloride that's being made. So you want to think about that when we go into a lab and we look at NG suctioning. Imagine what that's doing to your patient's chloride level, since the chloride is being released into the GI tract. However, your patients that have really severe vomiting, severe diarrhea, we can also see a drop in their chloride levels. Unfortunately, a really big challenge with a low chloride level is that it's usually going to be accompanied by some type of volume depletion state. And so the chloride level is going to decrease as my volume starts to decrease. And so what happens is the body's going to say, all right, well, I've got to try and correct this. And it's going to expect the kidneys to do some of that correction, which again is going to alter my bicarbonate level and change my acid-base balance. My patient at this point is likely going to be in metabolic alkalosis. So I really got to check the muscles. I've got to look for deep tendon reflexes. Oftentimes they're going to be hyperactive. My muscles are going to be overcontracting, even tetanic. And then they'll have weakness and cramps associated with it. Usually you'll see with hypochloremia that they also are hypokalemic, so their potassium level's low. So now I'm going to be concerned about cardiac function. Remember, when we see a trend in chloride, I often am going to see the similar trend in sodium. So your patient may be hyponatremic. So I'm going to see seizures. They may even go into a coma. So for you as a nurse, when you're thinking about chloride imbalances, it's going to be really important for you to monitor your patient's level of consciousness as well as their muscle strength. And you've got to pay close attention to see if there's changes in either of those. And if there are, you want to quickly report that to the healthcare provider. Oftentimes, in terms of the treatment, they really want to fix the underlying electrolyte imbalance as well as the acid-base imbalance. So there are certain types of IV solutions that we can give. We can even do half-strength IV solutions to try and replace the chloride, but at the same time, we also have to be addressing the other electrolyte imbalances. Sometimes if my patient is getting a diuretic that might be dumping the chloride, because it's also going to be dumping the sodium with it, they may actually hold those for a while or try and see if they can switch to a different diuretic that maybe isn't going to be as potent for dumping those agents. So we have talked about a whole host of details related to very specific electrolytes. But remember, what we're talking about here is concepts. We're looking conceptually. So yes, it's important to understand what occurs with each of the electrolytes individually, but overall, if I'm looking at my patient as a whole, my holistic patient, the electrolytes are going to be changing, the fluid's going to be changing, the acid-base balance is going to be changing all together in a variety of different ways. So you've already learned a variety of very specific focal system assessments. And you need to complete the focal system assessments that are relevant based on your client's electrolyte levels. But you also have to have a general overall understanding of really key assessment findings that are going to be your cues that you as a nurse are going to use to help you recognize that your client may be experiencing an electrolyte imbalance. So if you start to see some cardiac changes, let's say you see a change in the heart rate or the rhythm, you may make an SBAR report to a healthcare provider and say, I really want to take a look at my patient's potassium and calcium levels. Could I have an order for that? If I start to see that my patient has a change in their level of consciousness, I may want to consider, what is my patient's sodium level? What is that looking like? If your patient's electrolyte balance is within normal limits for their age for a healthy adult, the vital signs should be within normal range. The patient should be alert. They should be oriented ×5. I should see that their intake of fluid and their output of fluid is equal or within 50 to 100 ml of each other. When I'm checking muscle strength, the muscle strength should be +5. I should see as I move them through different range of motion and they're moving themselves, all their different joints through different range of motion, it should be very fluid. Additionally, as I weigh my patient every single day, their weight should be consistent. I shouldn't see excessive gains or excessive losses. However, if my patient's electrolytes are kind of out of balance with each other, remember, we're thinking conceptually, whole big picture, my holistic patient. Well, I might find that my patient has tachycardia. They could have an irregular heart rate and rhythm, so I don't have an even space between each beat. Maybe they've got some dysrhythmias that start to show up all of a sudden on the EKG. My alert and oriented patient that morning on my shift when I come in a little bit later in the day is now confused or disoriented. That could be a clue to me. Oh, I wonder what their electrolytes are like. When I think about musculoskeletal status, they might have weak muscles. We start to see twitching. I'm thinking neuro even more. My patient might develop seizures or even go into a coma. I want to really pay close attention to their urine output because remember, a significant change in urine output, either they have too much urine output or not enough urine output, could indicate to me that there might be something going on with their electrolytes. It could be a fluid issue, it could be an electrolyte issue. So I want to do daily weights. Is my patient's weight changing day to day? So all of these things are cues. These are cues that I as a nurse have to recognize that tell me, hey, I need to take a look at my patient's electrolyte panel. What are their electrolyte levels and what imbalances may be going on? And just based on my assessment findings, I should be able to identify what my top concerns are and what I need to communicate to the healthcare provider. So given that this is so important for me as a nurse to recognize cues in my assessment findings that indicate an electrolyte imbalance, it's important that I start thinking of what are those little red flags going to be that indicate that this may cause an electrolyte imbalance. So if my patient comes in and they've been vomiting for 5 days straight, I'm pretty much guaranteed they're going to have some type of an electrolyte imbalance. Their body's going to try and compensate, but there's only so long that my body systems can compensate. If my patient has a burn injuries can really cause a lot of electrolyte imbalances. If your patient's bleeding out, whether it's external or internal bleeding, that hemorrhage is going to change your electrolyte balance. We're going to look quite a bit in this class at kidney function and liver function and how those can alter electrolyte imbalance. So as you get report on your patient, you want to be picking up on what are the cues that you see in report that indicate to you that your patient may have a potential electrolyte imbalance. And then whatever that electrolyte imbalance is, what do I need to do in my assessment to ensure that I identify it early? And what is the nursing care that I can give to prevent that imbalance from occurring or the complications from that imbalance that may occur? So those are really the big areas that we're going to dig into in class. You've got the basics, you've got a nice review from your first few semesters in nursing school, and now we need to dig deeper. So you've had a good review of basic electrolyte concepts, and we're going to continue with our work in the classroom on application. So we're going to work through some cases in the class. We're going to look at some NCLEX style questions in the class that are really going to help you apply what you've learned into patient care scenarios. I also want you to start thinking about potential complications. That's a big part of this semester, is recognizing when something is wrong or recognizing that something could go wrong, but I as a nurse need to identify this early and work with the healthcare team to correct it before it actually progresses into a worse state. So this finishes our section on electrolyte balance. I know it is a super long one, so please take a break before you dig into our last section. Our last section is going to be looking at the concept of acid-base balance.